Good afternoon. Welcome to Best Practices and Potential Barriers in Implementing Rapid Clozapine Levels. I'm Megan Ehret. I'm a professor and co-director of the mental health program at the University of Maryland School of Pharmacy. I'm excited to be presenting today and providing some real-world tools and information regarding rapid clozapine levels. As part of the presentation today, I am disclosing that I am an advisor for Saladex Biomedical. In this role, I help to determine webinar topics and discussion and information that is provided to you as members of AAPP. So if you have other thoughts, we're going to be continuing these micro webinars into next year. And we'd love to hear about other information that you need regarding clozapine levels, or therapeutic drug monitoring. So please send me an email, shoot it out on the listserv for topics or thoughts that you might have or interest in for any of these micro webinars. I'm also the pharmacy expert for SMI Advisor and receive funding from the Maryland Department of Health. Please note we'll be using the question and answer feature today. So as we near the end of the presentation, if you have any questions, please go ahead and drop those, I believe, in the chat. So excuse me, in the chat box, and I'll make sure that we get to those questions at the end. So the overview for today's mini webinar, we're going to briefly talk about clozapine immunoassay, and I'm going to tell you a little bit about the role that the immunoassay has played at our institution, so at the University of Maryland Medical Center. We're all aware of the need for rapid clozapine levels, but we'll go through a little bit about what's happened at our institution and the need for that, and then look into the benefits of clozapine, results in hours instead of days. And I'm excited to show you what's happened at the university. We'll talk about best practices for implementation, and I'm going to share some of the things that I went through when trying to onboard this immunoassay and how we tackled those hurdles and jumped through all of the hoops and are up and running. And then thinking about best practices moving forward using these clozapine levels. So hopefully this builds upon some of the previous micro webinars, which are housed on the AAPP website. So if you want to go back and review those two webinars, that would be of great interest as well. So at the university, we have been working to implement these clozapine levels, and we went live last Christmas. And it was very memorable because when we did go live, the emails from psychiatry were, "It's a Christmas miracle. We're finally doing our levels," because we had been talking about this for well over a year about implementing this at our institution. So this has really had an enormous impact on our ability to treat patients in real time. We've started improving our reinitiation protocols, and we'll talk a little bit about those changes that we made in the presentation as we go on today. We've been improving our therapeutic drug monitoring utilization, looking at discharge planning, and then patient access to clozapine. So very quickly, within the last 9 months, we grabbed all of the patients that had the immunoassay ordered, and then compared that to the previous time when we were using our send out, and looked at average time to clozapine result. And we were very happy to see that we were going from about 87 hours for a clozapine result to 4 hours when we started doing it in-house. So we are now able to make much more quick, efficient decisions regarding any patient who's receiving clozapine with this new in-house result. We're well aware that there is a need for clozapine levels. I think many of us now have a better understanding of clozapine levels and the need for those in not only assessing efficacy, but also to help manage adverse effects. And really best practice is to provide those results as quickly as possible to assist all of our mental health professionals in making any decisions regarding medication dosing. So clozapine, we're well aware, only effective medication for treatment-resistant schizophrenia. Therapeutic drug monitoring is strongly recommended. If you're looking for any background information on clozapine blood levels, great, excellent book sits on my desk, the Clozapine Handbook, also antipsychotic blood levels, two excellent handbooks that I would recommend picking up if you're looking for any of that. The therapeutic drug monitoring is growing in psychiatry and is really an effective tool for assessing the patient's status and various clinical settings. Without these, we're really left with little insight, and we're just making clinical assessments. And we know those are very inaccurate over the course of time. When we implemented this blood level, now we're getting our levels within hours, and this is really providing vital information. So we are now able to quickly kind of determine that questionable medication adherence. So when patients are coming in the ER and we have that questionable adherence, and now we know that perhaps REMS may not be as helpful because sometimes that information is not up to date. Pharmacy claims data doesn't help us ensure the patient has taken the medication. And so instead of waiting a couple days, now we're able to know pretty quickly, at least in a ballpark range, where our patients are. Looking at biological variations affecting drug metabolism as we move forward into this fall, and we think there might be an increase in COVID. Again, adjusting our clozapine levels is much easier now, instead of knee-jerk reaction, making cuts of a third to a half in all patients, and then having some decompensate and some still experience toxicity. We can much more accurately dose our patients. And then those that maybe not having that expected response to the dose that we're giving them. So the old method, the send out, the liquid chromatography with mass spectrometry cannot provide results fast enough for us. I mean, that 87 hours is several days. And in that course, if we have someone who we hold the dose for several days, then we're stuck retitrating. So it is much more efficient to do it in-house. And now there is the FDA cleared laboratory assay available. When we considered the immunoassay at the university, I myself was definitely a champion, Deanna Kelly, Ray Love, among others who also were wanting to champion this here at the hospital. And it took a little bit of work. And so I wanted to sort of share that story with you today as you prepare to potentially embark on this same journey. So what do the stakeholders need to know? So first, we had to approach our administration, talk about the clinical necessity for both inpatients and outpatients. So we approached the directors of pharmacy, the Department of Psychiatry, and really thinking about our clinical utility of clozapine. And we really presented some data on the risk of not measuring levels. And so we had reports in the literature of clozapine being restarted at too high of a dose, the literature on non-adherence, and then a lot of the COVID literature about not measuring levels and some of the ramifications of that. The impact of timely results on clinical decisions and hospital length of stay is very important. We're working now to gather the data post-implementation to look at some of this real-world data and knowing that we can make faster decisions. Obviously, cost of incorrect decisions, in particular, if patients end up with toxicity or they end up underdosed, that they could be risk for re-hospitalization. Cost avoidance, cost of not using clozapine and having patients re-hospitalized. And then the cost of in-house testing versus send-out testing. And so this is very important as well because the lab directors are very interested in budget, as I learned. The next step we approached the lab director. Sometimes you have to do a little searching to find out who the lab director is. At the university, I also found out that there is a lab committee, and this committee approves new lab assays or immunoassays as a group. So I approached the lab director and set up a meeting to talk about the clinical need for these same-day clozapine levels. Took a little bit of time to bring them up to speed on what is clozapine and why do we need to do it in-house when we have a send out. And some of the pushback you might get is, we'll get the send out back in 3 days, or, we'll try to do it faster. And so thinking about what your clinical need is. The costs, we did talk about costs of rehospitalizations, readmissions, sitting in the ER waiting for information about whether the patient was going to need to be hospitalized. We got a lot of questions about, well, we don't do very many of these clozapine levels now, so why do we even care? And explaining that we don't do them because what we do isn't very useful. And going through, and we pulled all the numbers for how much clozapine we prescribe and how little numbers were actually drawn. And thought, if all these people are really receiving clozapine, our therapeutic drug monitoring should be increased quite a bit. But people aren't doing it because it's not very useful in the amount of time it gets back. And so we anticipate that volumes will increase once we are able to do it in-house. We needed to bring in someone who speaks lab, and I'll say it as easy as that many of us as pharmacists or other healthcare practitioners may not understand all of the ongoings in the lab. But what's important to know is these are FDA cleared reagents. They use the same methodology as other major diagnostic companies. And it's a really fast implementation because they run on the same equipment that's currently in the lab. So the equipment that runs your complete blood count or your CMP can also run this clozapine immunoassay. So there isn't an additional equipment buy. It's really looking at the reagents and setting up the validity of the test within your lab. So the real asks there are they willing to give you some time on the machines when you do need these clozapine levels? Of note, many times when talking with the lab personnel, we would send emails and maybe didn't get responses. The best advice I can give you is it's very hard to turn people away when you're standing in their office. So there are many days that we spent in the lab going there to remind them of the importance, continuing to ask, when this would happen. And ultimately, our lab committee found to be extremely valuable to have this. And we were able to get this up and rolling within our lab over the course of a couple months. We then went and educated our psychiatrists, talking about how workflow could be improved, thinking about inpatient and outpatient, and the impact this could have on patients. If you saw them in the morning, got their blood, were able to get the level within 4 hours, and either call them or have them stay for a group, and then be able to think about the new dose that they might need that same day, and talked through scenarios where clozapine levels would be beneficial. Definitely discussing with your consult service, the ER providers, anyone that might be in that critical need for a clozapine level, and thinking about now having this available. When you think about best practices for implementation, here are some of the key bullet points to think about as you approach your hospital administration or outpatient administration. And I should also mention that it may not even be at your own hospital or institution. I know in the state of Maryland right now, we're working with outside providers outside of the university. We're also looking with our state hospital system to see if a courier service can courier the blood over to the state hospital or to the university where we're running these levels. So if you have questions about maybe one of the institutions in your state that might already have this up and running, and if you are able to sort of send or courier your patient's blood there, please reach out. I'll be happy to sort of forward those questions on and see if we can find out where the nearest location might be for you. So thinking about in-house testing, once we had the reagent validation done and the clozapine test was ready to be run, we really needed to initiate the IT workflow to offer the new test and making sure that all of the critical lab values were determined, steps and policies on when the lab would contact providers and how all of that would get set up. We also reached out to our Epic team to change the default ordering clozapine to our in-house method. So this way it would support the utilization of the rapid test, but still allow for the send out if you needed it. But that way everyone wasn't having to change the default test when they just typed in clozapine level or into the lab order set. So we have that sort of up and running now. For psychiatry, we did consider education on differences between the old and the new test. The old test is the send out, takes a little bit of time, but gives you the clozapine and the norclozapine level. The in-house test provides the clozapine level. So information on the value of the clozapine level and what are some of the potential uses for the norclozapine level, and when you might want to think about the send out, how to interpret those results, really looking into the differences. Defining workflow improvements. So thinking about the outpatient clinics and how providers might not have to wait 4 or 5 days, or, hey, we're going to get a level today and at your next appointment, we'll review it. Thinking about how do you make those follow-up phone calls when you need it. Impact on interpretation. And this is really want to support the lab to answer clinical questions about establishing your therapeutic range and alert levels. Revisiting 60 days post-implementation to determine what works best. And so we've been working around our outpatient clinic and making sure all of our providers are aware that they can send patients immediately to our lab to have this drawn. For the ER and our medical teams, it was really informing them of the ability that this test was there and they can order it. And so when patients potentially come in with a history of clozapine or are currently taking clozapine, and we need to sort of have guidance about, is this patient going to need readmitted for a retitration? Have they even taken the last dose? What sort of action are we taking? That's important. If they're there for medical reasons, there for COVID, contacting psychiatry to make sure that consult is there as well to help interpret those results. For our patients and caregivers, really thinking about communication on why you might be starting this testing. If you haven't done clozapine levels, why you might be doing it now, and the benefits to their treatment plan. We've heard success stories from patients and caregivers who are very excited about the opportunity to have more information that, yes, I'm at a therapeutic level, I'm doing well, or maybe I'm not doing as well as I want, and my level might allow for some increase. So I think there's great opportunities here for discussion with patients and caregivers to really engage in therapy and conversation around the clozapine level. So some of the barriers, we've kind of talked a little bit in our very short and quick time about the barriers that we've had to some of these things. The no metabolic ratio. So when you do it in-house, there is no metabolic ratio. We sort of envision this at the university as sometimes we just need that rapid clozapine level. I need to know. And that's more important to me than the metabolic ratio. I need to know adherence. I need to know if I can retitrate. I need to know where this patient is now versus waiting 5 days to get that metabolic ratio. If I do need the metabolic ratio to look at potential metabolism or a drug interaction or something, I can still do a send out if needed. The test volume being too low, this was definitely a barrier that we encountered immediately with our lab director. We don't do enough of this in order to do this. So we definitely had to do a lot of education about the utility and how our testing would increase over time. We're hoping that our outpatients who might have been clozapine candidates, that now people will have a more comfortability with prescribing clozapine, using these test results, that they would be able to increase the utilization. And also partnering with other institutions or providers. So now there is some outreach into Baltimore and the surrounding providers to know this is available. So our university has it. If your patients want to come over, we can order this. And we're also working on setting up courier systems with our state hospital systems, which covers, as many of us are aware, some of the sickest patients within the state. This is a change in methodology, but it is an FDA cleared test. It's manufactured in the US. So it does have very good data behind it. So thinking about best practices before we jump into questions, excuse me, reinitiation protocols. This is a big area. Providers are able to make real world clinical decisions versus waiting several days. The patient has a therapeutic level. I apologize, one moment. I should have brought water with me. I apologize. Okay. So providers are able to make real world clinical decisions versus waiting several days for the level to come back. So if the patient's at a therapeutic level, we may continue the current dose, consider a dose increase if clinically indicated. If the patient has a supratherapeutic dose, we might hold or discontinue the medication or increase monitoring for adverse effects. If the patient has a subtherapeutic level, we could consider a dose increase if clinically indicated, or increase monitoring of symptoms for the patient. So really being able to customize the patient's response. When we think about discharge planning, the goal really is to be able to provide the current therapeutic level prior to discharge. That way, we as outpatient providers have a better determination in the future of the current level. So looking at the previous levels and symptomatology to predict what is occurring with the patient in real time. So having knowledge of previous levels is key to understanding what dose the patient might need in the future. We're hopeful in looking at our discharge patients, and we're doing an ongoing chart review to look at the ability to restart clozapine and continue clozapine when levels are available within hours. So instead of waiting several days and wondering or making a knee-jerk reaction decision, we're able to potentially restart clozapine or have the patient continue without retitration much quicker. And this improves communication with the next provider by providing important information on how the patient was treated. We also have better determination of the level and therapeutic effect. So thinking about some of the things that we have going on. Changes in manufacturers. We get a lot of questions and consults about my manufacturer changed and I have this new side effect or a new symptom occurred. Thinking about, okay, I had a level before on this manufacturer and understanding what that was. And maybe as we look at the new manufacturer, do we have the same level? And really comparing historical levels to assist in making a decision if we need to increase the dose or decrease based on symptoms or adverse effects. If a patient experiences an adverse effect, we now have the ability to get a level very quickly, to think about where they are. And we can move the dose a little or a lot and sort of have a better prediction of where they are. And having that baseline clozapine level when the patient is doing well is extremely vital to providing that personalized therapeutic level, especially as our patients move between different health systems. It becomes very valuable in understanding the current level that the patient is on. So as we wrap up here, rapid clozapine levels have improved patient access to clozapine by providing critical blood levels. Our providers feel more confident in prescribing clozapine. Having objective medication data is better all around. Having more information, I always think, is better. Quality transitions are occurring with vital information being passed from inpatient to outpatient or between providers. And the routine clinical practice is supported by the availability of this just being in-house, and has made it so much easier for all of our providers. And as we continue to move forward with clozapine, this has definitely been a feather for us at the university. We're super excited to be able to offer this to the surrounding areas as well, and sort of be a leader in clozapine levels. So the references for today's presentation are here. I want to leave a few moments. I know we're right close to 12:30, but if there are questions that someone quickly has in the chat about how we went about our clozapine levels, or any of the things, I'd be happy to engage in that conversation. As you're thinking through any final thoughts, if there's other information that you feel would be very helpful, please let me know. We want to continue these micro webinars into the next year. So happy to move some of those topics forward. Or if you need help establishing this immunoassay at your hospitals, also reach out. Again, happy to help in any regard that we can in helping facilitate conversations. And if you are just looking to see if there's a hospital or an institution near you that might already have this up and running, please let me know. We'll be able to hopefully make some connections, assist in any courier services that you might need to help with that. I want to give everyone an opportunity. So we have about a minute or two left if there are any other questions, or people are pretty quiet today. If not, I want to thank Saladex for the opportunity to present some of the information that's going on at the university. We're very excited that we were able to onboard this and really help all of the patients that we serve. So thank you, everyone, for your time today.